Hello, and thank you so much for exploring this applied learning presentation. My name is Bove. I'm a physical therapist and an assistant professor at the University of Pittsburgh. In this presentation, I'll be sharing how we used electronic health record data from a large health system to identify sociodemographic disparities in functional outcomes and in rehab use after joint arthroplasty surgery. The healthy people definition of health equity is stated here. Basically, achieving health equity requires us to eliminate health and healthcare disparities, which we'll define next. Health disparities are differences in health that have a close relationship to some type of disadvantage, whether that be social or economic or environmental or other. In joint arthroplasty, we know that there are disparities in utilization of the surgery and in short-term outcomes after the surgery based on race, based on sex, and based on economic factors. What's less clear is whether and how rehabilitation plays a role in those disparities, and that's what my team studies. Amy Kilborn and colleagues provided a three-phase framework for health equity research. So phase 1 studies on the left here focus on identifying disparities between different groups of people. So most phase 1 studies use large data sets to uncover disparities. An example of a phase 1 study might be a study using Medicare data to describe utilization of physical therapy after a hip fracture between men and women. Phase 2 studies in the middle focus on understanding those disparities. These often, but not always, use large data sets. And sometimes there are qualitative components as well. An example of a phase 2 study might be taking existing data showing racial and ethnic differences in care received and looking at how the type of insurance, the type of hospital or type of physician seen, or other factors like employment or marital status impact that relationship between race and ethnicity and the outcome of interest. And finally, phase 3 studies focus on intervening upon health disparities. This can happen at many different levels, from a single practice or community to the entire country or the entire world. For example, it could be argued that passage of the Affordable Care Act was a phase 3 health equity intervention because it expanded access to insurance for so many million people who couldn't previously afford it. But on a smaller level, this could be something like one hospital implementing processes to measure social determinants of health with their patients and require the provider to do some type of brief intervention or conversation with the patient to help connect them to resources that may improve their health. When we seek to understand why disparities exist, we can look at several different levels. Often the early phase health equity research focuses on patient-level factors shown on the left-hand side of this graphic. Those patient-level factors are a mix of modifiable and non-modifiable traits. But it's really important as providers and researchers that we also consider factors related to us, to the provider, and how that patient and provider interact. And those might be much more modifiable and good targets for interventions designed to reduce disparities. And then at the top of this graphic are factors related to the healthcare system, which should also be considered key targets for implementing changes aimed at promoting health equity. So in the study I'm talking about today, we looked at patients receiving hip and knee joint replacement or arthroplasty surgery. These surgeries are an expensive and growing part of our nation's healthcare, but they're also really successful surgeries that have shown to have high satisfaction rates and to be cost effective. But there are known disparities by race, by sex, and by economic factors in the utilization of arthroplasty surgery. Patients who are female, who are Black or African American, and who have lower income tend to have the surgery later or not have it at all, which can impact outcomes even if they do eventually have the surgery, because pre-op function predicts post-operative function. We also know that there are similar sociodemographic disparities among those who do undergo the surgery. Patients from disadvantaged populations are more likely to have their arthroplasty in a low quality or a low volume hospital. They have longer hospital stays with more post-operative complications, have higher readmission rates, and higher rates of manipulation under anesthesia and revision arthroplasty surgeries. And there's evidence pointing to disparities in post-operative rehabilitation processes, such as my mentor Janet Freeberger's work that showed that patients from disadvantaged populations are more likely to be discharged to less intensive rehab settings, and others' work that showed poorer functional outcomes among disparity populations. What's lacking in currently available research is how that utilization of rehab impacts functional outcomes. Most of the existing research has looked at either rehab utilization or functional outcomes, but not both. In addition, most studies have focused on total knee arthroplasty, and there's little information about total hip. So in this study, we attempted to bridge that gap by looking at both knee and hip arthroplasties, by looking at both function and rehab utilization in the same populations of patients, and by looking at a variety of sociodemographic factors, including race, sex, socioeconomic status, and geography. Using the model that I shared earlier from Kilborn and colleagues, this study would be described as a phase 1 health equity study. So for this project, we obtained 5 years of electronic health record data from the University of Pittsburgh Medical Center, which is a 40 hospital system in Pennsylvania, Western New York, and Western Maryland. We had data on all hip and knee arthroplasties, but for the purpose of brevity, I'll focus the results on knee arthroplasty. One thing I want to mention is that my employment is at the University of Pittsburgh, or Pitt, but not at the University of Pittsburgh Medical Center, or UPMC. So to obtain the data, I went through a resource called R3, which is a medical records data warehouse that bridges the gap between researchers at Pitt and providers at UPMC. We obtained permission to have a limited data set that included dates of service and patient zip code, but other protected health information were not in the data. Next, I'll talk about some of the tools we use to measure our outcomes in the project. So for home health rehab, we used items from the OASIS instrument. That's the required assessment tool in home health. So we followed a process described by Fortinsky and colleagues using the OASIS items that are related to activities of daily living to calculate an ADL composite score at the evaluation and discharge visits in home health. So this gave us sort of an overall summary of that patient's function within the home. We also use the list of diagnosis codes from the EMR for each patient to calculate an Alex-Hauser comorbidity index using a free tool that's provided online by HCUP, the Healthcare Cost and Utilization Project. And their website includes the SAS programs and the instruction manual. As a marker of socioeconomic status, we used area deprivation index. So we used state level ADI, which is in deciles ranging from 1 to 10, with higher numbers indicating greater area deprivation. Our data warehouse was able to pull this variable for us, but if you don't have that option with data that you're using, you can use a free tool from Neighborhood Atlas depicted here, where you can enter an address and obtain the ADI for that address. And finally, we used patient zip codes to put into HRSA files, the Health Resources and Services Administration, to categorize each patient as residing in a rural area or a non-rural area. So this table just depicts the inputs and outputs for each of the tools described in the previous 4 slides. And if you're interested in any of those tools, you can pause here or pull up the slide deck and look at what information you would need as an input and what you would get as an output for each of these tools. We focused on community level rehabilitation, meaning the home health and outpatient settings, not inpatient. In home health, we looked at the number of visits and the length of the episode of care as our primary utilization outcomes, and then that previously mentioned ADL composite score as our primary functional outcome. And then in outpatient therapy, we also use the number of visits and the length of the episode as our primary utilization outcomes, and then we use the NEAT outcome survey as our primary functional outcome. Other health systems might use different measures of function. In UPMC, we use the NEAT outcome survey, which is a 0 to 100 scale, patient reported, where higher numbers are indicating better knee-related physical function. Our 4 main sociodemographic predictor variables were sex, race, area deprivation, and rural residence. Because our service area of UPMC has fairly limited racial and ethnic diversity, we only examined non-Hispanic white and non-Hispanic Black race because we did not have enough patients of other races and ethnicities to make any significant or convincing conclusions. For each outcome of interest, we looked at descriptive statistics, the correlations between those 4 sociodemographic predictor variables and the outcomes of interest, and then we built several regression models. We built those models in 4 phases that are described here. So first, we looked at the unadjusted main effects of each of those sociodemographic predictor variables on functional outcome and on rehab use. Second, we looked at the main effects of each of those predictor variables on discharge function within each setting, home health and outpatient, after adjusting for common demographic and clinical variables listed here in blue, as well as adjusting for baseline function. And then third, we additionally adjusted for rehab utilization to understand how rehab utilization plays any role in the relationship between those predictors and discharge function. And then finally, we looked at that interaction effect of that sociodemographic predictor with rehab utilization on functional outcomes. So what did we find? So for each of the 4 main sociodemographic predictor variables, I have a slide like this with detailed results. Feel free to pause the presentation or access the slide deck if you want to read these in more detail. But because we're supposed to keep this presentation relatively short, I'm going to breeze past the detailed results and instead provide you a 1 or 2 sentence summary. So when looking at disparities by sex, we found consistent sex disparities after knee arthroplasty, where women had poorer functional outcomes despite using more visits and having longer episodes of both home health and outpatient rehab care. We found very similar patterns when looking at race, where Black patients had greater rehab utilization but poorer functional outcomes than white patients in both settings. When looking at area deprivation as a marker of socioeconomic status, our results were more mixed. There was not a clear relationship that emerged between rehab utilization and functional outcomes based on whether a person lived in a high deprivation or a low deprivation area. And then finally, we compared rural to non-rural patients, and we observed very few differences between them. So I'd like to end by discussing some of the pros and cons of conducting health equity research using electronic health record data from a large health system. Some of the pros are we could be relatively certain that the providers within UPMC Home Health and UPMC Rehab Institute were fairly consistent in their approach to care because they're colleagues working in the same system, using the same protocols, the same approaches, et cetera. Being at Pitt meant that I had easy access to the data warehouse and its analysts, and I could easily add variables to the data set as long as that was something that's available in the data warehouse. And that cost was relatively low compared to purchasing a Medicare data set or Optum data or other EHR data sets or claims data sets. This was a lot more cost effective. Cons of this approach, some data elements were simply not available. For example, our original plan was to look at Medicaid or dual eligibility as our marker of socioeconomic status. But when we received the data, we realized that we couldn't tell which patients were dual eligible or who had a managed care Medicaid plan. In Pennsylvania, most of our Medicaid is delivered via managed care plans from third-party payers. It's not delivered directly by Pennsylvania, but through insurers like UPMC Health Plan, like Highmark Blue Cross Blue Shield, et cetera. And the way that the data were coded, I couldn't tell if someone had a employer-based commercial UPMC product or a UPMC Medicaid product. And so there was going to be so much misclassification bias that we had to change gears a little bit and find a different way to denote socioeconomic status, which is how we ended up using area deprivation index, because that was available from the data warehouse and was more consistently available. Because this was EHR data, I didn't have access to claims, so I don't have any information about costs of care. I also mentioned earlier that there's limited racial and ethnic diversity in the UPMC service region, so that is a limitation within our system of trying to look at racial and ethnic disparities. And then finally, when using EHR data, it's just really important to remember why these data were originally collected, which was not for research, it was to provide healthcare. And so sometimes there will be limitations that frustrate us, but we are not why these data were collected. So we just need to work with what we have. Some remaining research questions that our team has are described here. So we're currently working to understand what the most successful combinations and timing of home health and outpatient rehab after arthroplasty are. and how we could get that best or most successful pathway implemented in a way that's accessible to all patients to promote more equitable functional outcomes after surgery. That first question we are tackling with this same EHR data again. And the second question, knowing what the barriers might be to implementing that best rehab path, we're tackling primarily through qualitative data collection. And this third question, what changes could we make to that rehab pathway to allow more optimal personalized care so all patients can have better outcomes, will require greater integration into the provider side, into UPMC, which will be a challenge for me because again, I'm employed on the PIT side, not on the UPMC side. And so that's a limitation of me being entirely on the academic side and not on the clinical side. So we will be partnering with UPMC Rehab Institute and surgeons on the UPMC side and using some implementation science methods to study that and try to find feasible targets to improve our rehab pathways so that all patients have access to the best possible outcomes. Thank you so much to the LeaRRn investigators and their team for inviting me to create this applied learning case. Here's a reference list, and I'll pause here if you'd like to access any of the resources. They're all listed here that I mentioned in terms of measuring outcomes. I'll go back to thanking you.